Good evening, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. This is a COVID 19 World News special report. Today we are going to be focusing on intensive care unit patients' outcomes from three different areas from around the world. First, we're going to look at the New York City single hospital experience involving 4,103 patients, which was just recently reported. Then we're going to look at the Lombardy multi-hospital Italian study. We're also going to look at Wuhan, China experience and see what lessons we have learned, what unanswered questions do we have, and how do we go forward. COVID-19 pandemic, New York City study. It's a single institution study which looked at 4,103 patients who presented to the hospital who were found to have positive coronavirus tests. The time frame was from March 1 to April 2, 2020. Let's look at the results. Christopher Petrelli and his group reported in medorziv.org. You can look at the reference here. They had a total of 4,103 patients, of which almost 2,000 patients were admitted to the hospital. Out of 2,000 people, 49% were discharged. That's the good news. But the rest of it tells a different story. There was a 14.6% overall mortality in the group of 2,000 people who were admitted to the hospital. 445 patients, or little over 20% of the patients admitted to the hospital, were on mechanical ventilation. And look at this. Those people who were on ventilators, there was a 36.4% mortality. That's much higher than we have seen in some other studies, which we will talk about in a minute. But I wanted to keep this in mind because you have a 2 out of 3 chances of coming out alive, but at the same time, there is a 36% chance of a bad outcome. They looked at various factors that may be accounting for this high mortality among patients who were intubated or maintained on mechanical ventilation. And of course, as we all know, age over 65 had a much higher odds of having complications and deaths. Similarly, BMI over 40 was another risk factor leading to increased deaths. And of course, the heart failure, which goes without saying. When they looked at the clinical parameters, oxygen saturation of less than 88% was a significant predictor of bad outcomes. And of course, the D-dimer and CPR, all these follow only after we have a situation where the oxygen saturation is rapidly deteriorating. So, when we look at all these things, we can't change any one of these risk factors. The only thing we can focus on is the oxygen saturation. That is, if we prevent patients from going into oxygen desaturation by early interventions using drugs or plasma transfusion, hopefully maybe we can change the ICU outcomes. But by the time we see an oxygen saturation of less than 88%, and when these patients go on ventilators, there is a cascading of events leading to pulmonary infiltrates, fluffy patches on CAT scan, and intravascular coagulation, finally, cytokine storm. The strongest indicators of a bad outcome in patients who are in the intensive care unit were age over 65, obesity with a BMI of greater than 40, and an oxygen saturation of 88%. And of course, procalcitonin, which may suggest superadded infection, in the presence of viremic destruction of the lung tissue. Of course, this is one of the initial reports from this largest study in the United States from a single institution. We would like to know if there were differences in treatment in the various subgroups or in the first 2 weeks compared to the second 2 weeks. Do they have any data on use of hydroxychloroquine and azithromycin? Do they have any information on who received the plasma transfusion and if there was a difference between those who received plasma transfusion versus those who did not receive plasma transfusion before it was FDA approved? Let's move on to the Lombardy study from Italy, which was reported by Giacomo Garcelli. I hope I'm saying it right. They reported a study between February 20th to March 18th, 2020. They had 1,300 patients admitted to the intensive care unit, and 99% of them were on respiratory support. 88% of these patients were on mechanical ventilation, and their ICU mortality was 26%, which is a little bit less than what was reported in the New York City study. Now, here is the Chinese experience from Wuhan, and this was reported in JAMA Network. Here's the reference. Jinyu Wu and Jennifer McGugan reported this on February 11, 2020. The total cases confirmed were 44,672, and the critical cases were 2,087, accounting for 5% of the population that tested positive for the coronavirus. And the mortality in their group was 14.8% in patients over the age of 18 years, and the mortality was 49% in critical cases, assuming these are all patients who were in the intensive care unit and perhaps were on ventilators. So there is a substantial amount of morbidity and mortality among those patients who are admitted to the intensive care unit, and when these patients go on ventilators, the outcomes become less favorable. Putting all these things together, we have the Wuhan experience with 49% mortality in critical cases. Then we have the Lombardy Italian study, which showed a mortality of 26% in ICU patients. And of course, the New York City single center study, which reported 36.4% mortality among patients who were on ventilators. Again, the criteria used by different institutions vary, so it's not right to compare these numbers, but nonetheless, the bottom line is when a patient is in the critical care unit, they have a much higher mortality, and it gets worse if they go on ventilators. That means the time to address all these issues is when their oxygen saturation levels are dropping and before they need the assistance of mechanical ventilation. Going forward, here are some of the things that we can focus on. They have learned a great deal dealing with these patients. Now they have better criteria for intubation, like early intervention, better ventilator managements, like using low tidal volume, PEEP. In fact, there have been questions raised about the ventilator-related damage. In the coming weeks and days, we should be having some reports on hydroxychloroquine and azithromycin combination in the United States, which may help us to understand if this combination is useful. Many of these patients are getting different combinations of antiviral agents, so it will be interesting to see if these antiviral agents make a difference in patients treated in the intensive care unit. And I want to focus on plasma transfusion. What is the rationale behind using plasma transfusion? It's based on the fact that people who have been exposed to the coronavirus, people who have recovered from the coronavirus infection, have reasonably good titers of IgG and IgM, which might help patients who are in the intensive care unit who have decompensated to help reduce the viral overload, help reduce the lung damage. Presumably, yes. Think of it this way. When we give a vaccination, what are we trying to accomplish? We are using part of the virus or something that can stimulate the body to produce the IgG and IgM. And if that antibody, the IgG, can protect the individual for months and months, why can't we use the antibody from a recovered patient which should be doing the same purpose on an acute basis? There are several anecdotal cases which have clearly shown improvement in these patients, and in those studies where there was no significant improvement, it was probably related to the fact it was used as a last resort of treatment for patients with far advanced pulmonary decompensation. But I strongly believe if antibodies can prevent the viral multiplication and reduce the pulmonary damage, the time to use plasma transfusion is early when patients are having a desaturation of their oxygen level. It suggests it's the beginning of the pulmonary damage. And if we use the plasma transfusion, 1 or 2 units is all that is needed to reduce the viral multiplication, hopefully, and reduce the pulmonary complications and reduce the overall mortality in the intensive care unit. That's my 2 cents. What do you think? How would you approach a patient who is showing early signs of decompensation? Thank you so much for watching this presentation, ladies and gentlemen. Please do subscribe to our YouTube channel, and please do watch the video which I have created on plasma transfusion. Everything you need to do to accomplish plasma transfusion. Even if you're in a tiny town anywhere in the United States, you can get an FDA approval to treat 1 or more patients with plasma transfusion. I hope you'll be able to save many more lives with some of these new insights in managing critically ill patients in the intensive care units all across the globe. Please do subscribe to our YouTube channel. Thank you so much.